talk about, and we've done it before, about questions and things you've heard before, maybe that you weren't quite sure they were persuasive to you enough, or you got some questions about, how to do something that you've been advised before, or just that one question, you wish you would have asked your doctor, but you just thought about it at the parking lot when you left. And so I'll give my first disclaimer, which is I am not taking care of you today in this session. So that I am not your doctor. I am not replacing your doctor's advice. So I tried to be really careful about that. But if I am implying that I am superseding your doctor, please note on the front that I'm not. I'm not trying to do that, but I will give my opinion because that's what this is for. To hear a different voice essentially about things. And if I don't know anything about whatever you're asking me, I'll tell you, because I think that's the better way of handling those kinds of questions. So every so often I venture on opinions, so be careful. I usually say this is not more than what the next person will say to you at the bus stop. That's the cue that I'm giving a really opinionated opinion and not really a scientific or a medical kind of well-informed idea. But I do have plenty of opinions, so I got to figure out a way of giving them. So anyway, so anybody has anything they would like to chat about or talk about? Yeah.
Yeah, I would just need to see my cardiologist, and I got a form for a national survey on cardiology, and so I enrolled in that and filled out the questionnaire, and I'm wondering, where is this going? How long is it lasting? Why is it only limited to 3 questions per month or something like that? Because that seems a little macro for something that looking for a little change.
Got it. So let me ask you a couple more questions just to see if I know which one specifically you were doing. Was this at UC Davis?
Yes.
And what did they call it? The heart share study? Heart share?
It could be. It was a printed out thing that Dr. Wong said we're doing this, and said you were the connect person to it.
Got it. Did they use my name for this? Was I involved in the study?
Yes.
Oh, so it's got to be the heart share.
Yeah. Okay.
Yeah, it's the heart share. So heart share, it's a great question. And this is what occupies most of my time for the last 3 years. Heart share is a consortium from the NIH, and it is intended to recruit patients throughout the entire country, the United States, with patients with heart failure. And so there are 2 kinds of heart failure. There's the heart failure with what we call reduced ejection fraction, and then there's the heart failure with the preserved ejection fraction. And so just not to get too technical, but just to give a little background on this, your heart is a pump. And so the ejection fraction is how much the heart takes in with every beat. And the ejection fraction is how much it can actually squeeze out at every beat. And it has to do this, 60, 70 times per minute. And so the ejection fraction is just that amount after it takes 100%, how much it can put out. So usually it's about 60% of what it puts out. And so some people with heart failure, it takes 100%, but they can only do 30%. They cannot quite squeeze enough out. And so their heart failure is with reduced ejection fraction. So they're doing this instead of doing the normal, which is like this. That's one kind of heart failure. That heart failure we've studied for decades and decades and decades is the most detrimental to people. And so it's had lots and lots of clinical trials. We have about 6 different kinds of medicines for it. We got all kinds of procedures and defibrillators and all kinds of, we know a lot is what I'm trying to say about that kind of heart failure. And, that's the care we do every day. Keeps us really busy because there's a lot of patients with this condition. But we have a lot of things to offer, and we make a lot of people feel really good, and we, prolong people's life really well with what we have, and we still need to do more. But now, then we have here the ugly cousin and the nutty cousin, heart failure with preserved ejection fraction. It turns out there's more people with that condition than the people with the reduced ejection fraction. But until just less than a year ago, we had 0 medications for it. So no treatment for it. In the last year, we've learned that some medications make people a little better, feel better, and some medicines keep people out of the hospital a little bit better. No cures whatsoever. And we don't yet have any medicines that reduce the mortality from it. So in other words, total failure of research to figure it out what to do for these patients with the heart failure with preserved ejection fraction. So HeartShare is the NIH project where they actually got seven universities, of which UC Davis is one of them, to recruit patients into this registry, this national registry, to that have we're recruiting people with the heart failure preserved ejection fraction. We're recruiting people with the reduced and the preserved, both, and then we're recruiting people that are normals. So we're recruiting all that, and we're trying to get 10,000 people at UC Davis. So each place is trying to do 10,000. I'm sorry, I take that back. We're doing 10,000 total. UC Davis is going to do 1,700, 1,600. Divide 10,000 by 6, whatever the number comes out to be. That's what we're trying to do. For the registry. So we're asking all the patients in the clinic to come and do that. And then we ask you to do surveys, which you do in the computer, if I had to guess. And then, yes, every so many months, they'll send you for just a short little survey, just essentially to keep track of you, to see how you're doing. And I think at the year mark, there'll be another longer survey that they'll send you. And as long as the NIH keeps funding it, we will then continue sending surveys through a lifespan of people. So some of these studies that the NIH has funded since the 1970s, they're doing the grandchildren of the people who sign up first at this time. We don't know yet the NIH will fund this in that length, but we're hoping that it would. So we're funded for 5 years. So this runs until 2027. So that's how people, that's what you're doing by contributing to the surveys. It's just sharing your experience, whether you're in one group or the other, and that's not important in the second, but whichever group you are, we're asking the same question. So we want to see what is the history and the journey essentially that people have with hospitalizations and other complications, what medicines and whatnot you have taken over the time and whatnot. There's a small group of people out of the 1,400 or whatever we're going to recruit for the registry. There's about 150 of them that we're going to ask them to do a very, very intensive protocol of exercise and CT scan and MRIs and blood testing and EKGs and special blood pressures. A really, really intensive protocol. It takes two days to do. In fact, that's what I was just doing at 10:30. I did one of the study patients that we're doing this, the bicycle CPET, which is the one with the mask on oxygen, and then they exercise and we get and they do it with an echo at the same time. So we get pictures and the gas exchange and the EKG. We're essentially going back to the drafting table. What is it that we actually know about the patients who have this condition? And then once we try to understand better what we actually do know about it, is then can we come up with medication targets, new targets to develop new therapies for them. So it's kind of a long-term journey to going back to the beginning of it, kind of like accepting that we don't know anything about it, because we've done over 150 clinical trials that have failed. So after you do the same thing multiple times and you keep getting the same failed result, at some point you have to figure out and say, maybe we don't know what we're doing. And so we've tried for 30 years and it hasn't yielded very much. So basically the NIH said, go back and do the basic studies again. Get the basic physiology, get the basic blood tests, get the basic imaging again, try to span as much as you can of the body, the human body, patients, and let's go back and see what can we learn and understand better about this condition to come up with therapies.
I have siblings who have the same cholesterol problem, and I'm the one who had the heart attack, and they did not. Would they be possible candidates, or do they have to have the heart attack to get the ejection fraction question?
Mm-hmm. Yeah, for this, they would have to I don't know if for the registry if they need to be a UC Davis patient.
Well, they're national. They're
Yeah.
Colorado and New York, so it would be.
Got it.
You would have to get their local.
Right.
Equivalent.
Right. So the places where they're doing this at, so we're one of 7. They just got Johns Hopkins on board, but the 6 initials was UC Davis. Then you're going east, it's in Chicago. They got Northwestern. They have Mayo in Rochester, Minnesota. And then they have Wake Forest, Massachusetts General, Brigham, and there's one more, UPenn. And that so if they're close to any one of these centers, then they can participate through the different center. So I tell everyone that we're the only ones west of Chicago, Minnesota, the area. So that usually motivates people to sign up. It's like, oh, I want to be part of that. It's a east-west thing, but it's all observational, and we're just really going back to try to learn what we can from the condition, about the condition, how it affects people.
Dr. Lopez, could you clarify that condition again? Did you say that?
It's called heart failure with preserved ejection fraction.
So you have a regular or you have a normal range ejection fraction?
Ejection fraction, but you still have heart failure.
But then how do they determine the heart failure?
Nobody's paying attention at home.
There's
Give her a 2 stars. So
there's a test called BNP.
That's right.
Is that the one? Because my doctor just ordered it for the very first time and I'd never heard of it.
Yeah. So I'll answer the first question is how does that happen? And then I'll explain the result, the test. So as I said, the ejection fraction is how much you put out. So the people with preserved ejection fraction, they still put out 60%, but they have a hard time filling up. So they don't have a hard time going in the squeezing. They have a hard time relaxing their hearts. So if you try to take a balloon, which is stiff, and you try to fill it up, you got to put a lot of effort to fill up that balloon. Your cheeks get blown up, you get turned red. That's energy wasted to get that balloon to open up. If you have a balloon that is not that stiff, you just put a little bit of pressure and you open it up and fill it up. So the person's heart that has heart failure with preserved ejection fraction, it's unable to fill very well. So once it fills, it can put it out. But if it doesn't fill very well, then it just has the heart failure, meaning it's unable to pump enough blood because it just generates so much pressure and effort and wasted energy, but it doesn't put as much blood out. And so it is an ineffective kind of pump. It's a pump that doesn't really work very well, but not because it could not eject, it's because it cannot fill. So it's a filling problem, what these patients have. Now, the symptom-wise, they get the same symptoms: short of breath, they get swelling on the legs, they get fatigue when they try to do activity. You lay down in the bed at night and you feel short of breath, smother, because water kind of pours into the lungs when you are laying flat. You may have to sleep with 3 or 4 pillows, because if you try to go down flat or a couple of pillows, you just get restless and can't sleep. So that's what we call the congestive symptoms. And so with either heart failure, you can have congestive symptoms. The symptom doesn't determine what kind of heart failure you have. That's when your doctor orders tests, and the echocardiogram is usually the one that tells us the ejection fraction, and that's how we categorize normal ejection fraction with congestive symptoms, or you have reduced ejection fraction with congestive symptoms, and that's how we know which kind heart failure you have. The BNP is a blood test. It's a chemical that your heart releases when the heart is stressed, and it's stressed not from a psychological stress, but like usually I describe as stretch. If your heart for whatever reason gets stretched or is forced to do a lot of pressure, like in the HFpEF situation, then the cells in the heart feel the stress of that. It's mechanical stress. And then he releases this chemical that normally is not in the blood. And so when we draw it, if it's elevated, then that means your heart has been under stress from that stretching stress or mechanical stress. So when it's high, then it suggests that if you say I'm short of breath or I'm fatigued or I'm having a lack of energy, and your doctor does that test, what they're looking for is to see whether, okay, if that test is high, then that suggests that with that symptom, you also have some stress happening at the level of the muscle of your heart. And so it kind of helps us guide us in which direction to go next.
Thank you.
You're welcome.
Yeah, I want to ask another
yes,
question
please.
related about this. And so 2 questions. So I'm going to assume, does exercise help with the preserved ejection fraction? And if it does, what type is best?
Yeah, well, that's a great question. So we don't know that if you walk in the door and say, I have HFpEF, give me an exercise plan, that I would know exactly what exercise plan to give you to make you better. I don't know the answer to that because, and there's a study actually testing exactly that right now. They're actually testing cardiac rehabilitation in patients with HFpEF. And so it may take another year or two before we know the answer to that from a clinical trial. Today, we don't know that straight up. But there's a way around not knowing, which is I know other things that could help me actually guide you today on what to do. So for example, HFpEF is well known to be associated with high blood pressure. So high blood pressure is actually the number one thing that people with HFpEF have. It's the most common comorbidity, if you will, with this condition. 80% of people with HFpEF have high blood pressure. Well, we know the exercises that reduces the blood pressure. And so they ought to be helpful to patients with HFpEF who have high blood pressure. And I already spoke about the patient I did this morning. This patient, without giving any details of who they are, was not able to exercise very much because their blood pressure was 240 or 120. And so we were about to tell them to stop because that's actually reached the level of too dangerous. When they say, oh, I can't do it anymore. I say, oh, good, stop. So this person had, and they didn't exercise too much or that much. It wasn't like they were like, oh, my 9th mile, my blood pressure. No, they'd just been like, 6 minutes into it or something. So it's somebody who their blood pressure spikes quite a bit with modest amount of exercise, and then they become very symptomatic. So I can help that. I give you some medicine to reduce that blood pressure, and then you can then start exercising. Then we put you on a combination of aerobic and resistance exercise. So it's a combination of the two. And as your blood pressure continues to come down, then I take the medicine away. You feel better, you feel stronger, your blood pressure normalizes. If you stay on the medicine, usually less medicine, because the exercise will reduce the blood pressures. And some people even come off the medicine completely. But I usually treat the number first with the highest and as many blood pressure pills I have to. And I beg people not to throw them in the trash when I'm not looking. So we can get the number normalized, because your high blood pressure numbers keep you from exercising. You feel terrible. Why will you do it again? You keep telling me to exercise. I can't catch my breath. I can't get out of the couch afterwards. Why would I do that? But let me not tell him. And so we're not helping anyone. So I try to aggressively treat the number up front with medicines, and then as people do the lifestyle change, the exercise, the nutrition, the low salt, all these other things, as they start contributing to the lower blood pressures, then I start cutting pills in half, and then stop that one, and cut that one in half, and stop that one. And that's how we get then, 2, 3, 4, 6, 8 months down the road, we get to a place where you're, with the lifestyle you can carry on at the lowest medicine that actually gives you the result. And usually those people feel better from their congestive symptoms. Some people are just, I could say, too advanced, or just our situation is different enough that this doesn't work. But for 80% plus of people, this really helps at the get-go from when they have the heart failure, preserved ejection fraction. Managing the blood pressure. I can say the same thing about diabetes. It's not as clear with diabetes. The blood pressure is very clear. If I make that number come down, people just feel better like that. Diabetes takes longer. You need to get the numbers under better control, and it takes a little longer before you actually can tell that you're feeling better. But the same principle, if we can get the diabetes under control and the blood pressure under control, people in general will feel better, physical, more stamina, less fatigue, and then they can do more. When you feel better, then you do more, and it becomes kind of a positive cycle for you. So, does that help?
Yeah.
Yes, please.
In NB test, people for failure, you do tests to figure out how to use it. Started with a very high level, 2,000 something. And when I'm doing the test, he gave me medicine to take, and he dropped it to 500.
Oh, that's good.
I was happy.
Yeah.
next week, I went to do a test. Went back to 1,000
Mm-hmm.
and do a test every week. I go to a test.
This is the BMP test, right? That
Yes.
we're talking about. Okay. And why they want to know every week? Like, what's the reason to check it every week? That's what the doctor asks you to do, right? Right.
So you guys need that to be able to.
I don't. So that's why I'm asking why are they doing it? I don't routinely, I don't need it every week unless I'm changing the medicines every week. And then I want to know that I don't overshoot, for example. So if I give you too much diuretic and you are too dry because I give you a lot of diuretic or make you, urinate a lot, then that test will drop very low. And then I know, okay, he's probably, if you're not yet complaining about it, the test may tell you back off a little bit. So that may be a reason to do it. That's what I'm asking. Why are they checking that every week?
Pharmacist or monitoring,
Mm-hmm.
try to adjust medicine according to.
Yeah. Okay, so I want to be careful. We're talking about the same thing. There's a BNP, we call that B Nancy P, and there's a BMP, we call that B Mary P. Two different tests. The one I just said is the B Nancy P, which is different from the BMP, which is the B Mary P. We use the Nancy Mary to distinguish them. The BMP we do every week when we're adjusting the medicines for the same reason, toxicity of medicines and whatnot. And that's very reasonable. I do that every day on 50% of my patients, and that helps us guide the medicines. But that's the test that tells us the potassium, the kidney function, the sodium, the glucose. It's a test that gives us like 7 different things in it. So it's called BMP with M as in Mary. That's why we call it that way. So I just wanted to clarify, is that what they're checking, or is it the B Nancy P, which is the one I was talking about, the heart failure? And I don't mean to put you on the spot, but that pro, it has the pro in the front. That's the heart failure one. Okay, I got it. So UC Davis has the new. There's a newer version. It's called Pro NT BNP. That's the one that. Okay, got it. So that's the heart failure one. Yeah, again, I don't routinely do that. I know some of the other heart failure doctors that take care of a lot sicker people than I do. They do that when they're really making a change in something, and they want to just kind of make sure the change, they don't overshoot on the change. But at least in my practice, I usually say to people, how do you feel? And if they say I feel good, I got better, I don't feel as bad as I was 3 weeks ago, then I don't necessarily need to keep checking it. And I'll tell you why I don't keep checking it. It changes, just like you described. It changes from the morning to the afternoon. This test is very sensitive to what you're doing that day. So if you had a larger meal with a little bit more salt, that day it will be 1,000. The next day, you got a lighter meal or less water or something, it'll be 500. Did it make any difference to you? Probably not. You may not even be able to tell the difference. So small changes like that are very sensitive to what you exercise and eat and what you're doing in the moment and that kind of thing. So I don't find it to be that telling from a day-to-day, week-to-week. Again, unless I'm really changing the medicines and making adjustments in that way. Now a change from 3,000 to 500 is a large change. That's not just because you ate a little different today or you exercised differently today. That's really a big change that your body pressures and stress to the heart have actually come down. So that's good.
Population going up, down, and so on. I'm getting confused and frustrated towards.
Yeah, I hear you. Not to do with that, yeah.
The same diet, where they eat the same diet that I'm following. So
yeah.
One of the things that I noticed is that when there is some information that are done from, especially from TV, you turn TV on, advertisement of medicine. Yeah. Ask your doctor to prescribe me that. So if you're asking me to tell my doctor to ask me to prescribe me, what is the doctor is prescribing?
Well, that's what the people on the TV wants you to do, is that to exactly what you just said, is don't fall for it, please. They want you to tell your doctor what to do and not have the doctor decide for you or with you. Because they want us to prescribe their medicine and not the competitor's medicine. Yeah, no, TV, I stopped watching TV shows. I get confused myself. In fact, I get confused listening to the advertisements for medication. So I was like, what is that again? I never heard of that, really? And it is, I mean, as a human, I get really overwhelmed by the list of things that could happen to you. I'm like, you mean that even if that all can happen, I didn't need to know all that could happen to me, And the reality is that no one, all of that never happens to anyone. It's the point. These trials have 1,000, 5,000, 10,000 people. And so one person in one place had one thing, and then another person in another place had another thing. And then they tell you that all these things can happen to you, but they're not saying all of them could happen to you in your body at a lifespan. It just means any one of them could happen, but not all of them. And in fact, most people rarely have 2 of them or 3 of them ever happen to them. So the point is that we don't know which one is going to happen to who. And so my recommendation is you have a good conversation with your doctor about what they recommend, number one. Number two, what do they anticipate could be the most common side effect? And I usually try to tell people 1 or 2 of the most common side effects to things to prepare them for that. And then I leave the channel of communication open. Said, if something is different, something bothers you, then send me a message or let me know, call the office and let us know. And then we'll deal with it when it happens. That's how I handle it. Totally with you. I get overwhelmed too. And I try to ignore as I mute it when I see it or I fast forward. Some of them are very cute. The family is all dancing out there, going kumbaya, like this, which dancing is great. It's a good thing. So they could be very pleasant to watch, but be careful with what they're saying. So
why does taking the medicine want to make you join the street parade?
Well, so the ones that are currently overwhelming on TV are the ones related to diabetes and the weight loss ones. And the reality is that when people take these medicines and they start, so let me talk about this is very deep and close to my mind and my heart right now, because first of all the patients that I take care of in cardiac rehab are showing up on these medicines, or if they're not on them, we actually say, maybe they should be on it. So suddenly it's like becoming the most prescribed medicine in my practice. And there are 2 kinds of them. I'm not going to get on the actual details of the actual medicine, but there are 2 kinds of these new medicines. But it's a very interesting story. They were all being studied for diabetes. And they're actually not that great for diabetes when you're treating diabetes for the sugar. When you're trying to control the sugar, they're actually kind of weak at doing that. Okay. Metformin can lower your hemoglobin A1C like 2 points, 3 points. These drugs, they do a 0.5 point. So that doesn't look that great, But about 20 years ago, the FDA had the vision of saying to the pharmaceutical companies, I don't want you to show me that you can just lower the sugar. Show me that you can also prevent a heart attack or a stroke for somebody to die with diabetes. Because after all, that's, there is all the other things, the neuropathy and other problems with diabetes. But from my lens, as a cardiologist, this is the story I'm telling. So the FDA told them, show me that. So the pharmaceutical companies were all upset because now we got to work harder. We got to follow people 5 years to see if anything's happening. They were all panicking and freaking out. What's the best thing ever happened to them? Because they actually had drugs that actually prevent heart attacks and prevent strokes and prevent people from going to the hospital with heart failure. So they're not that great at changing your glucose, but they're actually pretty good at keeping you out of the hospital and keeping you alive safely without heart attacks and heart failure. And that's when these drugs became centerpiece of your 6:30 p.m. TV, because now every company has got 1 or 2 of them either on the pipeline or available. They're all fighting for all of us to prescribe any one of them, because every company that's studying now these kinds of medicines have shown that they all benefit people. So there's a good reason why they're all in front of you on the TV, and they want everyone on them. And because they can charge a lot of money. They charge the same as chemotherapy for cancer for these pills. And just remember, it's only 0.5% of the hemoglobin A1C what you're improving, but they do have beneficial for cardiovascular conditions. So the cardiologist started seeing this. Why is the endocrinologist is going to take over my practice? So they started doing their own studies now for just cardiovascular, independent of the diabetes. And long and behold, these drugs are good for you, even if you don't have diabetes. So we started using them now for heart failure. And I just said, just in the last year, we've got a little bit of medicine for people with HFpEF. And guess who they are? Yeah, are these medicines, the new ones that just came out that are on your TV? They're the ones we're starting to use for all our heart failure patients, because they keep people, they make people breathe better. So they feel more comfortable at home and going to the store and whatnot. And so there are fewer people are going to the hospital because they feel better. They don't yet extend people's life, although there's a little bit of signal that they probably do, but it's not huge effect. But it clearly keeps people out of the hospital and breathing better. So we are prescribing them, and it's been great for us. Some patients who with the other 3 drugs I had, they weren't getting better. I've added these new drugs and they're doing a lot better. So
And they're covered by their insurance.
they're covered, but they're very expensive. So, this is a social question we as a society need to handle. It's, if we put everyone on these medicines, what's the cost to society? One of them, the other thing that they noted was that people were losing weight. And so they became now the new weight loss medicine. So that's the other. So these 2 medicines affect the glucose, they affect your weight, and they improve your cardiovascular condition. Well, that's 80% of chronic disease in America. So that's why there are these companies. Every one of them has multiple of them. They're very expensive, and they're going to be on your TV for a long time. I think for at least another decade, we're going to be exploding on these, showing up and trying to do better on top of the other one and top of the other one. They're good. Now, why did I say this? That's good, and that's good for everyone. Why did I say this is so deep and close to me personally? It's because, like I said, all my cardiac rehab patients are now on these drugs. They have side effects that no one is talking about. And I'm seeing every one of them. And it has to do with low blood pressure. They're all very good at lowering your blood pressure. And what my colleagues, and I'm not judging them, and I'm not saying this is wrong, it's what we're being told to do. And I'm picking up on this variation, and we're planning to actually write it up to call attention to it. You put on 4 medicines for your heart failure, and then they give you the new one, which actually makes you pee more, makes you a little drier, and now your blood pressure comes down. And it's really interesting what they're doing. They go back and they start taking away the older medicines that you were taking. They don't think that it was the new one for the diabetes that they just put on, which doesn't have as good in the clinical trial magnitude of benefit. So I am questioning, why are we stopping the lisinopril? Why are we stopping the beta blocker, which have very good track records of helping people save lives, for keeping the newer medicine in? And no one is deliberately doing this. I don't think we are taught to stop the beta blocker and the lisinopril when you have low blood pressure with heart failure. And so most people are not thinking that the newer medicines are actually also contributing to the low blood pressure. And that's the realization that I don't think most people are making, or the connection. So we looked it up in the clinical trials. There's a little bit of this. There's a little bit of blood pressure going down, but not very small, like 1.5% of people had the low blood pressure. Well, all of them are in cardiac rehab right now, because it's almost like half of them that are on these medicines, they end up with low blood pressures.
Could it be the combination of medication?
Not only medication, but the combination with rehab, which is the lifestyle. Earlier I said, the better your lifestyle is, your blood pressure comes down. So I think it's the perfect storm. You come in with heart failure, had a heart attack, something, the doctor puts you on all these medicines, including an extra one that will affect your blood pressure, and no one is thinking about it. Plus, guess what I do? I do this and tell them all day long not to eat the salt and exercise more and, meditation and do your relaxation, all the things that you guys hear around here, we tell them to do that. And God, if you do that, your blood pressure comes down and suddenly you're on the ground because your blood pressure is too low. It's the combination of the lifestyle and then too much medicine at that point. And then the heart failure people get really upset with me because then I say, stop the medicines. And they're like, no, they have heart failure. They're crawling in the gym, can't exercise.
They say like.
So, and they're like, oh, okay, I guess we'll stop it then. So it's really it's very early days. I don't think most people have seen this effect or are not paying attention to it. We're seeing tons of it. And so I become the medical doctor for most of the heart failure rehab patients because of this interaction
So
between.
could you review which of the medicines that are all different ones, or are they all on the same?
Same category. I don't want to make any advertisement one way or another for any names. It's just the same two categories of medicine. They're the new diabetes medicines.
Right, so there's the ones and the twos, right, of these, whatever they are.
Yes, that's right. There's the one and the two. That's right. That's it. That's the easiest way. That's the simplest way of thinking about it. Yeah, the one and the two.
Does it matter?
Both have different effects and both work in different way, but both can affect the blood pressure. The one that affects the weight, this is the other thing. People are losing weight. I mean, if you looked around, you probably have seen some people that have lost weight. So they work. These medicines work. But what I'm seeing is that they overshoot a lot. So people are losing weight a little too fast. And not everyone feels great when you lose weight too fast. And so some people are not feeling well with these medicines. And it's probably, my opinion, without being an expert on obesity or diabetes, is that it's probably they're losing their weight a little too fast. Healthy weight loss is probably a little slower because your body needs time to accommodate for the weight loss, and the muscle mass needs to build, and you need to do enough physical activity to build up muscle mass as you lose fat tissue, which is what we want ideally. I think a lot of people are losing a lot of muscle mass up front, and so they start getting fatigue and tired and not well. But they did lose 42 pounds, 39 pounds, 32 pounds in 8 months, 6 months, which is too much, too fast. Usually like to be 1 to 2 pounds per month. It's more reasonable. You're losing 6 pounds in a month. That's like, not good. Some of it is water. They lose a lot. Some of them lose a lot of water in the front, but at some point they actually start breaking down muscle and they don't feel so good.
Yeah, so talk about the sarcopenia a little bit, independent of these drugs.
Mm-hmm.
I mean, is that a huge issue, do you think?
I think sarcopenia is an under-recognized issue. And I think it's probably why most heart failure patients don't feel so good. Not the only, I mean, they have heart failure at the heart part of this, but the other reason why they don't feel so good physical activity wise is because of sarcopenia. Does everybody know what sarcopenia means? It means that the muscle mass has shrunken down. So, you got a big bicep, you go and work out, it gets bigger. You stop working out, the bicep shrinks down. Okay. Now, when that's hypertrophy when it gets big, atrophy when it goes down. Sarcopenia means that your muscles, without you doing any weightlifting or anything, the muscle continues to shrink down because you have heart failure or you're doing less physical activity. So if you sat on your chair for a month, then you can see your body, you just get thinner. Well, that's the muscle mass that went away. So the less you use it, the more you lose it. And so as we get older, we lose it faster. And if you get heart failure, you lose it even faster. So I think a lot of times the patient, they take the heart medicines, but they don't feel great. It's because they haven't yet catch up their body, their skeletal muscle in their body, the sarcopenia, which is what the term means. It's still there, which means they don't have enough muscle to move you around. The heart can pump a little better, but there's not enough muscle to move you around. So now if you put patients like this in an exercise program, a gentle, slow exercise program, because if we drive them too fast, they can't handle it. A gentle exercise program, then they build muscle mass as things are improved. They eat better nutrition-wise and things like that. They build a little bit better muscle mass. And we have seen some amazing people with ejection fraction. Like we have a guy, he's a supernatural. He's got a 15% ejection fraction and he runs 10 miles. It's like his muscle, his skeletal muscle, it works incredibly well. So he doesn't need his heart to deliver too much oxygen. So he's in the extreme, but that's what I'm trying to say. Your ability to do and your feeling from heart failure is not just the heart, it's the other organs in the body. And here, in this case, the muscle, the skeletal muscle, which is when you don't have enough of it, it's called sarcopenia. So yeah, so I am all an advocate for taking I mean, they're hard. These patients with heart failure are hard. They have a hard time in our program. Let me just say that. Because they're hanging around other people who had a heart attack and feel great. And they're like, and you know, with the heart failure, they're like, so it is hard. It's a difficult environment for them if they compare, and we're humans, we all compare each other to the next person. So they have a hard time. So we have a high dropout rate. So I try really hard to talk to them and try to avoid that they drop out. Because if they stick around a couple of months, then they can tell the difference. The heart attack patient who got treated very well, got put on all the medicines, in a couple of weeks, they usually feel great. But in the heart failure patients, it could take months and sometimes 6 months before they actually start noticing feeling better from exercise. So they have to be patient. So you know, I like to explain that to people and try to encourage them not to give it up too easily.
But you never thought of segregating your sections so that you did the MIs in the morning and the heart failure in the afternoon or whatever?
You know, my sections are segregated. There's the people that are outside and I can't bring in, and the people inside. So no, I don't separate them inside because I just don't have enough room, time, people, staff, all kinds of things. But that brings me to a point I wanted to bring up with you guys is we wanted to see if we could actually start expanding our doors beyond the doors of our gym at UC Davis. And one possibility is that, you know, using some of the space here for some of our patients who come out here, not just after they graduate, but before they actually even graduate from rehab. So there's an opportunity to segregate because we can choose and say this kind of patient can actually potentially go to Sac State and utilize the facilities there. So there's an opportunity there to select subgroups that would be alike. And then they hang out with people who have the same similar conditions, which I think, as you're alluding, it's better for everyone. It creates a sense of community. You compare yourself to people who have similar challenges, which creates a network of knowledge and support. And so for all the right reasons, I think there's some value to that. We just practically don't have the resources to do that.
So just up front, that would be an easy addition here, and the biggest hurdle would be staffing issues.
Mm-hmm. Yeah.
Maybe insurmountable, I don't know. That's the issue with staffing.
Yeah. So
You can have that conversation anytime you want.
I was going to say, can we have that conversation anytime you want? No, so I'll tell you what I was thinking. I mean, you guys have an open gym here. This is open. You come in whenever you want, you leave whenever you want. So my thought is just to do that, to keep it as an open gym for rehab patients, low risk. It has to be the low risk patients. I'm not going to allow the high risk patient to be here because exactly for what you say, you don't have enough staff to handle difficult situations. So we want to make sure that we don't create a scenario with difficult situations that we can anticipate, So there's always something could happen, even though we cannot anticipate. But so we'll probably start with something simple in terms of numbers and simple in terms of complications and type of issues they have. And I don't want to say a lot else in this space right now in this forum, because I want to be respectful of the people that will come. People that will come from the rehab program will be coming from a medical program. And so we need to keep their HIPAA privacy and confidentiality and all that. So I wouldn't be free to talk to the rest of you about their personal situation. I can talk in general, but not in terms of personal situation, because the relationship I have there with them is a therapeutic relationship. So I'll be the doctor. And so I can't talk freely about them in public. But, you know, I think to this group would just be more people that want to do stuff that you want to do. So I mean, it's all lifestyle, exercise, nutrition. And that's the reason why I think this is a great place for them, because I wish they would get what you guys get. I think our patients over there will benefit from what you get here in terms of the learning and the experience and exposures and things like that. So, and I'm sure there'll be some knobs and belts and things that and equipment you may need some improvement with, which we can talk about too. But I from an experience and educational experience, I think they'll get a great opportunity here. So,
Yeah, I got another question.
yeah,
Okay,
let's see how we're doing with time. We got about 4 more minutes because I got to be back in clinic by 1:30. So
you're gonna talk too fast. I
yes,
want to hear the definition of aflutter and afib. Kick in how heart rate affects them, high heart rate versus low heart rate. And also if you say anything about how each one is related to heart failure, particularly the preserved.
yeah.
ejection
Well,
fraction.
you need 2 years to do that to talk about that. But here's my short: AFib and aflutter. That's the they're both sides of the coin. They're just interrelated. They both happen in the atria. The fib is very chaotic and the flutter is very organized, but they're fairly similar on what they do to patients. So from what it happens, the flutter is a very organized electrical problem, where a fib is a very disorganized electrical problem, but they're both electrical problems in the atria.
And the heart rate's the same.
Both of them make your heart, if you have the rest of your heart is normal, that's the big if the rest of your heart is normal, both of them will make you have a very fast heart rate. Flutter could be a little faster, but they both fast, period. When your heart is going like this, you don't care whether it's 130 or 160. It's still too much. So it's fast. And
But
yeah.
Can't you have a disorganized or chaotic beat at a lower heart?
Yes,
Like
you can.
80?
I see it all the
But
time.
neither one of those is afib or aflutter.
No, you can't. No. Flutter and fib. Now, this is my disclaimer. If the rest of the heart is normal,
Okay.
if the rest of the heart is not normal, meaning you have a slowdown of conduction below, then you can have fib or flutter and have a heart rate of 80. It's irregular, but it's 80 on the average. It's an average. So you can have slower heart rates with fib and flutter. It doesn't always have to be fast. Relationship to heart failure, it's common with heart failure. So they're common occurrence. They happen together. There's a chicken and the egg issue there. You know, does one lead to the other? And probably yes. And does the other one lead to the other? Probably yes, too. So there's a chicken and egg thing. Which one did I get first? And that's a decision and conversation with your individual doctor about your individual situation. I would say that there's a specific situation where if you have AFib for whatever reason, and then you're fast for months usually, then you will get heart failure. It's not quite heart failure, it's just your heart just gets reduced ejection fraction. And then when we fix the heart rate position, then your heart returns, because it's not really an intrinsic or main problem of your heart. It's a problem with how you were fast for too long. And so those people, they recover and they go on, as long as we treat the AFib, they go on for decades, don't have any problem with the heart failure again. So then we say in retrospect, that was the heart rate did that. But there's a lot of people with regular garden variety heart failure who have AFib, and you fix the AFib, and the heart failure, a lot of times it gets a little better, but doesn't go away. So they both happen commonly. They can feed into each other. And there's a small number of people where one truly causes the other one, which is this one where the fast heart rate is persistent for months, usually, at least months. I think I touched most of your points.
I think
Yeah.
so too. Thank you.
You're welcome. Anyone else at home has anything they want to say or mention or ask before I go? It's a chat. There's something in the chat.
Thank you for coming in.
Oh, you're welcome. My pleasure. Sorry, we got started a little late.
Thank you. Do you have any thoughts about B12? A lot of people have started taking that for more energy and so forth.
You shouldn't take the B12 for more energy unless you check with your doctor whether you have a deficiency or a need.
Uh-huh.
You shouldn't just, of any vitamin, you shouldn't just take more of it because somebody or you read somewhere. Some of them can actually be toxic. some vitamins can actually be toxic to you if you take too much.
Mhm.
And most of the time, vitamins haven't helped people in general. The general population most of the time doesn't get any benefit from vitamin supplements. That's been studied. Different kinds of vitamins have been studied many times, and most of them are negative trials. There's no benefit over a sugar pill.
Right, thank you.
Yep, you're welcome. All right, I'm gonna have to go now. So thank you, everyone, and we'll do it again. If this works for you guys, then you make it a lot easier for me to come. I lose sleep I lose sleep the 2 nights before I come putting together a talk. So if this works.
Answer what?